morning, everyone, and welcome to Calgary. I hope you enjoy your stay in my hometown. So I have just taken on the new role as co-lead patient PFD partner with this group. And because I'm new in the role, I'm going to be listening and learning, and I do not have a lot to say from a patient point of view at this time. But I would like to announce that we have two really interesting talks upcoming. If you have any questions, please go to the mic at the end of the session. And for virtual attendees, raise your hand or put the question into the chat. So the following two presentations will consist of 10-minute presentations and a 5-minute Q&A after each. I'd like to invite Ms. Monica Bronowski to present the topic Urine Microbiota, Profiling in Renal Transplant Recipients During Acute Allograft Inflammation. Monica completed her neuroscience degree at Dalhousie University, focusing on neurotechnology. Before her PhD, she worked in hematology, oncology, and BMT, conducting clinical trials for multiple myeloma, excuse me, and CAR T therapies. She is now a PhD student at UBC's Department of Urologic Sciences, and she researches microbiome impacts on kidney transplant options. Monica?
Hi, everyone. Thank you for the lovely introduction. I'm Monica. I am a PhD student co-supervised by Dr. Lang and Dr. Harriman at UBC in the Department of Urologic Sciences. So my research primarily focuses on looking at how the urinary microbiome impacts kidney transplant outcomes. And then this talk today is just some of our work that we've done looking at the very early stages of transplant outcomes. But for disclosures, I have nothing to disclose. I'm a PhD student. All right, so a little bit of background on this. It was previously thought that urine was a very sterile substance because it was filtered by the kidneys. So it's filtering all this waste. There shouldn't be anything in it. But as we've seen advances in technology sequencing, we've actually revealed that this isn't true. So the urinary microbiome does have its own unique host of bacteria, bugs, all that good stuff living in there. And despite the discovery of the urinary microbiome, we have learned that there's really not a lot of work done on how it's relating to kidney transplant outcomes. So what we have started to do is we have been looking at the relationship between the urinary microbiome and kidney transplant outcomes, which is primarily what this will focus on. So for this study, what we did is we looked at patients who were receiving a kidney transplant at either Vancouver General Hospital or St. Paul's Hospital. So we had 42 patients that consented to this study and were enrolled. We were able to collect some urine samples at a variety of time points. So we collected before transplant, 1 month post-transplant, 3 month post-transplant, and at the time of cell-mediated rejection if it happened within 1 month of their transplant. So all of these samples were collected through a midstream clean catch technique. And once we had these samples, we centrifuged them down, collected a nice little pellet, and we sent all of that off to one of our collaborators at Cleveland Clinic so we could do some 16S sequencing. So what we came with is that out of all these patients, we had 5 really distinct groups that emerged. So we had women under 50, women over 50, men under 50, men under 50, and then we also had a group of early rejectors. And what's interesting is that out of our group of rejectors, so we had 10 of them, and 9 of them were men, 1 of them was a female. So that's what we decided to focus on a little bit here. We were able to take a closer look at our rejectors and non-rejectors. So the first thing we decided to do with our sequencing is we wanted to look at non-rejection versus age and non-rejection versus sex and see if any of that had an impact itself on the urinary microbiome and transplant outcomes. So we were able to look at both alpha diversity and beta diversity, so microbiome composition and function, microbiome composition. So what we found overall is that when we looked at age didn't really play a role in the transplant outcomes, but there was a difference between the males and the females, and so sex differences in their urinary microbiome, which we kind of anticipated. So then we decided to take a closer look at our rejectors and non-rejectors from the pre-transplant to the post-transplant period. So what we did here is we looked at their taxa. So we compared their pre-transplant samples to their 3-month post-transplant samples, and we were able to see all the taxa that they have. So pre-transplant, whole bunch of taxa, and then no matter whether they rejected or didn't reject, they had a general loss of taxa post-transplant. And we want to tease this apart a little more, and with our future research, we're trying to look into what exactly is gained, what is lost, how is this different by sex, age, all that fun stuff. So the overall thing is that no matter if they rejected or didn't reject, there is a general loss of taxa post-transplant. But then we also wanted to look at it from the individual level. So we were able to do some individual analyses. So once again, we're still looking at 16S here, and we were able to look at the changes in species richness versus their microbiome composition. And what we found, very interestingly, is that post-transplant, it looks like there is about a 75% new microbiome that wasn't there prior to the transplant. So in our recipients, we are working with the hypothesis that they are actually taking on the donor's urinary microbiome, which is very interesting. So to conclude this, the overall kind of takeaway is that there were no consistent differences between our rejectors and our non-rejectors, or between pre-transplant and post-transplant outcomes. But there were very stark differences in the microbiome composition from pre-transplant to post-transplant in both our rejectors and our non-rejectors. So where it gets kind of exciting here is that we are opening up some more studies now to really look into this at a closer level. So we've opened up 2 cohorts at Vancouver General Hospital. So we have a living donor study, which we have over 40 patients enrolled. We're looking at we're following both the donor and the recipient for 1 year. So from pre-transplant to 1 year post-transplant. We'll be able to look at their microbiomes throughout the whole thing. And then we've also recently started enrolling in a deceased cohort. So we're collecting some urine from the deceased donor at the time of donation, and then we're following those transplant recipients as well for 1 year post-transplant. And then we would also really love to expand this to the pediatric population. So we've been working on that, and we're trying to get things set up for that, so we can hopefully look at some pre-puberty, post-puberty changes as well, and see how it impacts the pediatric population. And this is a huge thank you to everybody that has been involved in this work so far.
Thanks, Monica. We'd now like to open up the floor to questions. Raise your hand.
Thank you. Great talk. So I was wondering, because we are talking a lot about gut microbiota and transplant through pills. So do you think that a gut microbiome transplant through pills could affect or improve the urinary microbiota?
I think it might. We're going to start looking into diet a little bit as well. So I know I'm working on developing a mouse model where we're really going to be able to control diet and see how that impacts the microbiome. And then we'll also be able to look at each immunosuppression, antibiotic, single usage, and see how that's impacting the gut microbiome and potentially transferring to the urinary microbiome. So we're going to hopefully do some stool sequencing, tissue sequencing. But I think our plan is to start that early next year in a mouse model. And then we're really hoping that we'll be able to transfer eventually to a patient population.
Great, thank you.
Hi, thank you very much for the presentation. You were looking at sex differences, but you also had gender on your figure. I was wondering if you were looking at sex or gender or both, and if you were looking at sex assigned at birth or how you were defining that.
So we were looking at sex assigned at birth. I should have clarified that. A lot of these samples were pulled from our biobank, so we do have a little bit of limited information on whether it was sex assigned at birth. So we after we pulled some of our demographic information, we went with sex assigned at birth.
Morning. I'm behind the pillar here. Really nice talk and some nice early work. I'm curious because these patients are also obviously getting massive doses of immunosuppression. Do you have any comparators where they're not receiving a new kidney? So patients who maybe have a kidney disease who get immunosuppression because of the disease, or vice versa, patients who are transplanted but that you delay induction of immunosuppression just to kind of tease out new organ versus massive doses of immunosuppression in terms of changing the microbiota?
Yeah, we haven't looked into that quite yet. I know we were kind of discussing it. I think our plan for early this year is to start a mouse model, so we can really tease apart immunosuppression, antibiotic usage, and then hopefully expand. But I think it would be great to also include some of those patients who are not receiving a new organ.
Hi. So this population tends to be heavily antibiotics use. So I'm just wondering, will you be looking at how that affects the microbiota and kind of offsetting that response?
Yeah, so we're going to track all of their antibiotic usage. So we've started tracking anything that's given in the OR as soon as they go in for transplant, anything that they're given prophylactically, such as like before they get their stent removed. We're also keeping track of any UTIs, any antibiotic usage for UTIs. So we'll be able to include all of that information in this study that we have open.
It was great. Can you just, I guess, describe a little more about the urine microbiota, kind of how it's thought it's acquired, right, and I guess its distribution in the urinary tract from glomeruli and then downstream after that.
Yeah, so our thought is that since we are taking this new tissue and placing it in, we're not really sure right now what the exact kind of transfer is. So what we've started doing is we've been collecting. We'll do it once our patient's in the OR. We'll collect our pre-transplant sample through their catheter, and then we have been really trying really hard to collect a sample at the time of reperfusion. So we're hopefully kind of teasing apart if all of that, the donor's microbiome is potentially being transferred right there in the OR, or if it's like an acquired, like environmental kind of thing that may happen later on. So we're still very early stages. So we're hoping we're hoping with this open study that we have that we can really tease apart what exactly is transferred, when it's transferred, how it's transferred, and hopefully get there. So we're hoping some of our reperfusion samples will give us more information.
No further questions? We've got time. Keep this poor woman on edge. Okay, Monica, thank you so much.